Okay, so very many thanks for the kind invitation. My interest in skills, drills, training and a little bit in education, as well as being a hands-on obstetrician. Keep going. Right, what are human factors? And I'm going to go over what human factors are. I know several of you in this room will have had, or possibly even heard me talk before, so sorry about that. But I'm going to talk about why they're important on the lay ward, and perhaps about a bit more about training and where we should be heading now. Next slide, please. This is the most important slide, I think, in the whole talk, because when things go wrong with non-technical skills and human factors, and they go wrong quite a lot, the real problem is that we are sometimes embarrassed. We're embarrassed to say something, or should we challenge the consultant? And he said take the left ovary out, and the notes it says the right ovary. If I say that, he might shout at me. Now, at the end of the day, if all that we did was say what matters most is not me being embarrassed, or the consultant being embarrassed, or the consultant being an arse. What matters is patient safety. That's what really matters. And I think that all our decisions should focus around that. Next slide. So human factors are two simple components, really. They're about non-technical skills which we have, the personal interactive skills we have. So when I talk about those, although I might talk in a bit more detail, they're not things that are new. When I first got into human factors, all I thought, well, I know all this, I just didn't know it was called that. But then again, it's about ergonomics, it's the environment we work in. You've heard something of that when you're running in situ simulation. It isn't just about the team, it's about the equipment you've got and the environment in which that equipment sits. Small corridors, small rooms, rooms where the bed doesn't quite fit through the door, all those sorts of things are the things that in combination with human interactions can lead to disaster. Next slide. Okay, and there's a definition. You're welcome to all these slides. I'll turn them into a PDF so you can get them later. So it's about enhancing clinical performance. It's about the interaction between systems, which are sometimes management systems, equipment, environment, and us as humans. Next slide. So I am going to concentrate for a few slides on these non-technical skills, which are an important element of human factors. So cognitive skills, situation awareness, decision making, leadership, communication, followership, teamwork. All those things are really important. Next slide. What I'm not going to dwell on are our personal resource skills, not because I don't think they're important, I think they're vitally important, but I just don't have time to talk about those. So there are strategies. I'll give you one strategy for coping with stress. But one of the things that's important with that bell-shaped curve is, at the top of the bell, we're moving in that direction, in increasing stress, and vertically, performance. And it's obvious that at some point, if we get overstressed or overtired, our performance will fall. And one of the dangers is, many of us don't realise that our performance is falling. So imagine, as I was a few months ago, dealing with a big PPH on a Sunday afternoon on an 18-year-old at 4 p.m, and at 10 p.m, when I was still in theatre with my head going buzz because she'd be done a hysterectomy and she wouldn't stop bleeding, we called another consultant in and sorted things out. Now, it's important, therefore, that the team have a role. It's about shared decision-making, which is something that hasn't happened, I think, in the hierarchy in the UK, and it's very pyramidal. I still go into shoulder dystocia drills, and as I walk through the door, the midwife sort of stands up and stops doing what she's doing. I mean, that is absolute madness. That's not what should happen. This hierarchical system in the UK really needs to be debunked to some degree, so that the whole team are involved in providing best care. Next slide. So this is my one of my take-home tools for you. If, like me, well, you'll be the anaesthetist, I walk into theatre always 15 minutes late. So I turn up, and the first thing said to me is, "Where have you been? Have you been? You're late again. What's happening? What's happening?" So there was me starting to not get too angry. So I think you pause and you go, before you respond and say, "Stop getting at me." You just pause, take a breath, and you say, "Am I hungry, angry, late, tired, stressed, or all five?" Usually all five, in which case you take a breath and say, I am a little late, I've been in the meeting, let's get on with this now. So pause and think sometimes, because you can get into a vicious cycle of anger within a team very easily. Next one. Okay, and you're all very aware of things like James Reason's slide, Swiss cheese, where you have defences, and holes in defences line up and lead to disaster. And this is a sort of human factors type Swiss cheese. So you'll recognise the things on there: guideline not updated, latent failure, staff shortages, latent failure just there all the time, and active failures, so we didn't monitor properly, we didn't pull in the consultant or senior staff early enough, and then something goes wrong. So that's just an idea of how systems and humans interact to lead to things going wrong. Next slide. Okay, how safe is healthcare? This is ultra safe. Look at ultra safe. Scheduled airlines, nuclear power. Look at unsafe, hazardous bungee jumping, mountain climbing. Next slide. Healthcare, very unsafe. Do not come and see doctors. Do not come and see nurses. Stay at home. You're much more likely to live. Right? If you could look through that slide when you get it, the one I've highlighted, next slide. The one I've highlighted is unnecessary surgery kills 12,000 people every year in the USA. Unnecessary surgery. Never mind surgery. It is dangerous to get near doctors. Next slide. So the problem is we're human, we will err. And therefore, one of the problems we have is that sometimes there are violations that occur, guidelines or deliberate sometimes. Sometimes we're not aware of moving away from what would be best practice. But what happens is we get away with a lot because the middle zone says near miss, zone of error detection and recovery. And that's where we want to really be astute and aware, so that we don't get into the far zone, which is adverse events, where you're detecting something going wrong. So this is where we want to be, and this is where we need to be aware. Next slide, please. Okay, you'll not see that from the back, but the important thing is this taxonomy of human error says there are different types of unsafe acts. There can be unintended actions or errors, slips, lapses and mistakes, and intended actions, violations. People sometimes do something deliberately. And that's really quite concerning, but can be done not necessarily maliciously. So you've got to be aware that human error is common. Next slide. Next slide. Okay, and be aware of biases. There are various biases that are very common. So the classic one is confirmation bias. So you're in an acute situation, you're a bit stressed, and when you're looking for things, what happens with confirmation bias is you actually over-egg the things that confirm what you think is going on already. And there's another thing called normalcy bias, where actually we don't really want to think things are going wrong. So we sort of go, well, that bit over there, that sort of observation tells me things are normal. And so you don't act in time because that we have inherent biases. And if you have an awareness of those, that's why I think this lecture, if you've never heard about human factors, is about getting you to go off and think about the things that might happen to you, that are a bit theoretical, but actually are real in that they lead to error, so that you are aware and know they're happening or potentially happening. Next slide. In labour we don't do particularly well, and you can see that human error is a frequent finding in intrapartum deaths, and this is KESDI data from a long time ago, before we started talking about non-technical skills. Next slide. So more recent data, look at this. This is the Daily Telegraph. Here we have the top 10 most expensive litigation trusts in the country, but totally unfair. Of course, you don't know their workload, you don't know their high-risk status, but there you are on the... But between those 10 trusts, in those 5 years, £670 million in litigation costs from things going wrong. Next slide. Worse than that, 500 million paid to lawyers. 500 million in 5 years. Okay, that's NHS litigation data. Next slide. So it's expensive. The issues in obstetrics, and again straight from KESDI, and now that you know what human factors are, you can see what they are. Failure to recognise, failure to refer, inappropriate delegation, lack of teamwork. If you look within our O&G post-grad curriculum, and I was chairing the training committee, they just had a meeting last week to radically review where we're going with our curriculum, and I guess you may be doing the same with yours. The work that was done leading into the change in the curriculum was really about what proportion of time by trainees is spent learning technical skills, doing sections for such, versus learning non-technical skills. What do you think the ratio is in the present curriculum? Have a guess. 50-50?
98.
It's 98-2 is a bit of it. It's 80-20. We spend 80% of our time in obstetrics teaching people technical skills. If you look at when things go wrong, what's the ratio? It's reversed. It's 80% of the time it's due to non-technical skills, teamwork and communication, etc., and only 20% of the time because you did something wrong technically. We are upside down. We are not going to make a difference to patient safety till we start teaching non-technical skills. And the problem is, how do we teach when half the teachers don't know what human factors are? So we're in a change, a time of change. Next slide. Okay, so again, just to show you Keogh report, if you look at the themes there that were recurrent problems, they're not technical skills, they're management, leadership, senior staff, skill mix in teams, inadequate escalation policies, inadequate CIRs. CIRs, critical incident reviews. If you read one book after this, get a book off Amazon called Safety at the Sharp End by Rona Flynn, which is all about human factors, non-technical skills. And it's aimed at the fact that generally in medicine, when things go wrong and you have a critical incident review, how many times does it really say that there's not enough staff and the management are useless and this, that, and the other? No. What happens is somebody did something wrong, they're at the sharp end, they get it in the neck. They're the one marched off the premises, suspended on full pay if they're lucky, while an investigation goes on, and forget that the sharp end is the result of many, many errors leading to that. So I'm going to show you at the end what Jeremy Hunt said about 4 weeks ago, which may be interesting. Next slide. If you believe anything Jeremy Hunt said. Embrace, the recent Embrace report. 17 deaths from hemorrhage. Look at the issues. Communication, ownership, leadership, teamwork. Problematic areas. That's us. That's us in this room, whatever we like to think. You all go, it's not me, I'm great, but it's us. Disagreements in estimated blood loss in 3 women. I've had that. I'm an old-fashioned obstetrician that likes to give blood. And I have had disagreements with my anaesthetic team. Oh, well, she's fine, she's fine, she's fine. I say, she's fine, she's fine, she's fine. But in an hour when she drops another 2 litres, she won't be fine, she won't be fine. So it's very difficult sometimes, isn't it, to professionally disagree in an appropriate way. But let's all bear in mind patient safety. Patient safety. Okay, so this looks at obstetric SUIs. These are critical incident reviews. And the worm analysis was looking at workmanship, which is basically technical skills, but others are admissions, relationships, mentorship, leadership, decision making. And the clear finding across 2 hospitals in London was 83% of cases exhibited human factors issues, and 79% of them, there were multiple human factors issues. So let's get the importance of this really high on the agenda. Next slide. You'll heard of Martin Bromley. He's an airline pilot. You can't talk about human factors. Some people are a little cynical. They say that, you know, what we do, flying a plane, if you do this, it turns that way. If you do that, it turns that way. You're flying the same plane. All our patients are somewhat different sizes, different ages, different shapes, and have different risk factors. But some of the principles are really important. So when his wife died, went to anaesthetist, lost situation awareness, and concentrated on intubating her for about 40 minutes, while her SATs were at 40%. How would anyone do that? How would anyone do that is the question. It happens. It happens to the best practitioners. And the real question is, how do we avoid it happening? And that's about good teamwork, better teamwork than we have now. Okay, next slide. So, quickly on to airlines. And next slide. Airlines, aviation accidents, 1970s, you wouldn't want to fly in a plane as a passenger because there were lots of accidents. And most of the time, it was what we have in medicine now. Failure to monitor and challenge the captain. Right? And now they've changed their systems, as you know. So I've really cut this down to 3-4 slides. So next slide is this classic disaster. You'll have all heard about in Tenerife, where two airlines, jumbo jets, run into each other. And the real issue was that it was a Swiss cheese. So they're in an unfamiliar airport. They're stressed because they want to get home. There's been a bomb threat somewhere else. They're stuck on the runway. There's fog. It's a tiny airport. There's loss of vision between the air traffic controller and the planes. Next slide. So the KLM Jumbo has Captain Van Zanten, who's the most senior pilot in KLM with the most junior first officer. And after 2 challenges, when he thinks he's heard that he can take off, and the first officer says, "You haven't had that. It says, when you take off." He said, "We're going." And so he went, and the Pan Am coming down the runway towards him that was meant to turn off at the 3rd exit in the fog missed the 3rd exit, so we're still on the runway. Next slide. Next slide. 600 people dead. Because of a failure to challenge and a failure to listen. Human error, 100%. Okay. It's just not quite as spectacular as that when we get it wrong. Next one. So that's why they introduced crew resource management. Alright, and now not all of crew resource management is relevant to us. Well, I'll show you at the end again that it is relevant, or aspects of it. So it's about knowing the environment, anticipating and planning, calling for help early, good leadership, good teamwork, etc. Use of cognitive aids, checklists. Next slide. Who's this? Young man. Anyone recognise this young man? This is him as an old man. Next slide. Captain Chester B. Sullinger. Now, he's the man you want at the controls of your plane when you're taking off from New York, and you have the unfortunate accident of 2 Canadian geese, 1 each into each of your engines. So you're flying there. What do you do? So you put yourself now back to a Category A caesarean section, or Category 1, whatever you want to call it. How many people say there's not time to do a checklist? No time to do a checklist because things will go drastically wrong. Okay, next slide. They all survived. All survived. Now, I know he's an experienced pilot. I don't think he practiced that too often in the simulator, so he used his experience. But anyway, they all survived. Why? Next slide. Several positive human factors issued. A good team, shared decision making with the first officer. They did initially go through checklists. They started the checklist just to make sure that they hadn't missed something like turning engines off. They realised that there were 35 things to check. They realised that there were 8,000 feet and it wouldn't be appropriate to complete the 35 items on the checklist. So checklists have a role, and I'd say the same in Category 1 sections. It's the time when you really critically want a brief, focused checklist before you run it. It's not the time to say, no, we're not going to do it. No baby dies in 20, 30 seconds. So I think I'm really keen that people use a modified checklist. Next slide. So this is a checklist. Do you know what this checklist is? This is the checklist from Apollo 13. This is the Apollo 13. You know, when you have to do the little bit of adjusting, and if you didn't quite adjust it right, they were going to burn up in the atmosphere. That's it. Now, I think that's sold for quite a large amount of money. But that's a checklist. That's all it is. Next slide. They reduce cognitive work. They help prevent never events. They change the culture of a team if you use them appropriately. But I see many surgeons rolling their eyes, I'm sure you do, thinking, why are we doing it? But actually, I've got more and more into them. And although there are advantages and disadvantages, I think the WHO list is great. And the best thing I use it for is at the very end of the checklist, what I do is I pause, and it's been good for me because it reminds me of everyone's names and those change. But I can go around every one at the end, and if it's the newest, youngest floor nurse, say to her, Louise, we're about to start operating. Is there anything you've heard in anything we've said that you think is wrong? And I do that with every single person at the end before we start. And I think that's the start of trying to remove this consultant people on the for barrier and hierarchy that exists. Next slide. So basically I say use a modified WHO checklist for your Category 1 sections. All right? You don't need to go through all of that. It could be just as brief of any maternal problems, just have a think, any fetal problems that we need to really deal with now, we've got the peds coming. So it can be very focused and very quick. Next slide. Let's talk a bit about decision making. To make good decisions, you have to have good situational awareness. So we'll start with that. Situational awareness is really, next slide, the business of being aware in a bigger way of what's going on around you, and the fact that as we become task orientated, we focus in and we lose that. So that if I'm dealing with a massive postpartum hemorrhage and doing bimanual compression and looking around, I'm not the person who should be really leading that. It should be someone stood back, the anaesthetist or the senior midwife, who can maintain situation awareness, because I won't be able to. The problem with situation awareness is it all happens at the front here. It's automatic. You can only hold a few chunks of information. Women can hold 7 chunks of information. Men can hold 5. That will explain a lot to the ladies in the audience, right? Next slide. So this is my little mnemonic. To maintain situation awareness, you step back, you collect information, you interpret it based on your experience, and the clever bit is you anticipate what's going to happen next. You tell the future. And that's what critical situation awareness is. And remember, that's a significant cause of error in acute situations. Next slide. So I could have showed you, as you've all seen before, I won't show you the gorilla in the room. That's why everyone shows the gorilla in the room. People miss the gorilla because you've task-focused them. Okay, so this is just another example. We sometimes see what we want to see. So those, to me, look like a black and a white dinosaur, but they're on different backgrounds. Next slide. Next slide. They're actually both the same colour. Just depends where you see the dinosaur, in what environment you're seeing it. So your environment is really important. Next slide. So, good situation awareness leads to good decision making. And there are different types of decision making, and this applies to midwifery profession, anaesthetists, doctors, every profession. Rule-based, analytical, intuitive and creative. Creative is rarely used. It's what Sully used when he was landing that plane. He hadn't done that before. It's like when I was called in a few months ago to a colleague on a 17-year-old having her first baby, where Kathy was about to do a hysterectomy. She tried to stop bleeding, couldn't stop, so it came in. And she tried a B-lynch, it hadn't worked. So I said, and I'd never done it before, but I just thought, how about we put a balloon in the uterus and then a B-lynch around the outside, which is well described now in case reports, and it worked a dream. So that's sometimes what you do, and that's sometimes just straight off the top of your head or based on thoughts or experience. Next slide. So rule-based is what learners do. They work to rules. It takes a lot of cognitive effort. It takes time. I'm always on the labour ward going, will you make a decision? Because I think indecision on the labour ward or delayed decision can lead to disaster. But one has to allow trainees to engage in a thought process. Next slide. Analytical or choice-based, as you get more experience, you bring in, I might have seen that, I'm not that experienced, but you start to analyse a little bit better, use mental models, you think about the consequences of decisions because you've seen something and you come to a decision. So that's another stage, next step. And then it's intuitive. It's what the experienced clinician does. You walk in, you go, we're going to do this because I know what's going to happen next. It's that quick thought process. Now that's a little prone to error, because if you don't pick everything up, you could go in the wrong direction. So it's useful to have a team around you who say, whoa, a second, if they think you're heading off in the wrong direction. Right. Okay, and then next slide discusses the creative one that I mentioned at the beginning, this rare form of can we do something out of the blue. Okay, next slide. That sums it all up, I think. George Patton. A good decision now on a labour ward is better than a perfect decision next week. And that's what the labour ward's like. You cannot sometimes wait for a perfect decision. Next slide. So here's an example of situation awareness, decision making on labour ward. The perception level 1 is the uterus is boggy, patient's tachycardic, the registrar recognises that. Says the most likely thing is atonic hemorrhage, we need fluids and uterotonic drugs. Projection, we need to avoid. Blood loss is 1.5 litres, send for the consultant now. not in half an hour's time. That's good situational awareness. Comprehension, interpretation, anticipating future state. Where things go wrong on the label board, and that's why level 1 is important. Next slide. 78% of situational awareness errors occur at level 1. People miss. And once you've missed it, unless you've got a really good team, it's missed for good. Next slide. So here's an example. We had a vaginal twin delivery going on, monitoring, several people involved. It became something of what people describe as fixation error. The whole team were concerned about baby 1, late decelerations, pH 3 times, consultant involved, registrars involved, midwives involved, pHs were fine. When the baby's delivered, twin 1 was fine and twin 2 was asphyxiated. Level 1 error, the team had missed, the leads were the other way around. And once it was missed once, it wasn't picked up again. Classic situational awareness, level 1 error. Next slide. Okay, this is a real case of ours. This shows the problems of confirmation bias, decision-making errors. So if you just look at this CTG, which I know audio anaesthetists will say be great with. Next slide. There's a big bradycardia for quite a long time. And then can you see it's sort of coming up with slowly. This baby is not making a rapid recovery. If you could read the writing, you will see here. Now, what team would do this? Increase Synto to 28 millimoles per litre, or moles per litre. No, it's right saying, it's really quite strange. This is where I work. How does that happen? How does that happen? But it happens a lot. Keep going. Bit of attack, so we give some penicillin. Look, still coming up to tachycardia. Oh, Synto up again. Next one. pH. What a surprise. 7.07 base excess minus 15.6 went to neonatal unit. And, fortunately, made a very rapid recovery. But we'll see in 3 years' time. Now, how does that happen? I don't know how that happens. But it's to do with poor decision-making, poor communication. It's to do with non-technical. It's not a technical skills error. It's a complete non-technical. And that's what we've got to be aware of. Next slide. Leadership and followership. 5 minutes to go. Right. Keep going. Next slide. So the 2 slides, when you get them, describe all the things that a good leader should do. Anticipatory, decisive, not bossy. See that all the time, don't we? Next slide. Collaborative, understanding, resilient, models appropriate behaviour. Motivation. Next slide. So, effective leaders, that can be any of us, have a high emotional intelligence quotient. So, next slide. That takes half the room out, doesn't it? Next. What it means is you can manage other people's emotions. That's what it means. Now, that's a difficult thing to do. That's what good leaders exhibit. Next slide. Okay. Followership, which is the thing people may not have heard of, is that the role of you in the team is not passive. You should constructively criticise where needed. You should participate in decision making. You should call out when you think something's wrong. You should challenge. Next slide. Okay, if you don't, this is what happens. You know, they're going to take out the man's good kidney. What do? They take out the man's bad kidney, but they take out the man's good kidney, his only good kidney. And the sad thing, next slide, the medical student was watching news of one kidney but was too scared to see him. That is a disaster. And that shouldn't happen if you put patient safety at every level in front of you. He should have been able to pipe on and say, you take me one kidney. That's followership. Next slide. So that requires assertiveness, and some are more assertive than others. So get person's attention, challenge them, and if they say, well, I think you're wrong, you may have to challenge a second time. It's really important. Next slide. So here's a mnemonic to help you with followership. Next slide. P, probe. Do you know that? You're not quite ignorant. If they don't listen, I'm a bit more concerned now because, challenge, please stop what you're doing because the next emergency, I need you to take action immediately. You've got to stop. I think there's a big problem. So I think one has to be prepared to be challenged. That means a leader has to actively listen and the follower has to actively challenge, and you have to work out that relationship. It's a different relationship. Next slide. Communication, of course, is vital. It should be direct, explicit, it should really be focused, and it should be specific. You know, don't say, will someone go in the music, will someone get the blood from the lab? Surprisingly, 5 minutes later, you haven't got any blood, because there is no one in the room called someone. You sometimes have to be rude. I don't know your name. Would you please go and get the blood? You'll then come back to me, closed loop. I'm going to go and get the blood, and I'm going to go, yes, please. Okay, closed loop communication. Next slide. For the back of the room. Yes, that was very loud, but I said I wanted to hear your heart. Right, next slide. Okay, SBAR. You know all about SBAR? SBAR is just a variation. Identify first who you are and who you're talking about. The R has 2 R's, recommendation, and then we've added in a RAG status, red, amber, green. Is this a patient, red, amber, green? Next slide. This is our new label board, so it's set out in identify, situation, background, assessment, recommendation. Have you noticed how much space there is for each patient? Very little. It's paper-based, and that's on purpose. That's to make people focus and tell you what really matters. And then we have a RAG triage, which is red, amber, green, just broadly, and that's reviewed at 8:30, 1, 6, 8 and 0300 in the morning by the senior team on the ward. Okay, so you review your patients on an ongoing basis. Next slide. Okay, I want to show you the last slides from Jeremy Hunt. So I'm going to leave a few out, so you'll get them. It's about teamwork, you can read those. So just fly through. I don't know, keep going. Just pause there. This is good. This is the difference between, hit the button, the difference between a Premiership football team that know each other well, common aim, which is money. Ourselves don't work together all the time, acute obstetric team who need to work in in-situ simulation. And what's the difference? Hit the button. An expert team versus a team of experts. Subtle difference. Next slide. Keep going, keep going. This is all about the NHS. Right. Resource management. I said I'd come back to resource management near the end. And this will help you. This is by Gabba. I think anaesthetists may well have seen it. Look, it's more or less all the things that are in with crew resource management. But it's very similar. And if you use that sort of approach, using the team, good communication, clarity, shared decision making, things will get better, for sure. And practice it in in-situ simulation. Next slide. Keep going. Practice, practice. The teamwork, we'll keep going. I'll just keep going through these. Helicopter views, stand back. You can read all of those, and we've talked about it closely. Right. Paul, go back one. When you do drills, try and use something like this from Prompt, which looks at the technical skills someone turned up and did. And this, far more importantly, clear communication, specific task allocation, little noise, closed loop communication. That's the checklist you want when you're doing a drills assessment. I don't know if you use that in your in-situ simulation. Next slide. And it works because if you train people, things happen quicker, so you give magnesium quicker. Keep going. If you do cord prolapse, you get to theatre quicker, and you, next slide, you have less GAs. So team training in situ and also the work, for sure. There's objective data. Next slide. Okay, keep going. I'm going to fly through all this because I just love talking about tactical decision games you can read about. NOTS is all about assessing. Now this is the important bit. Go back one. Last slides. NHS management must be involved in human factors implementation. They need to pay for training. They need to give you time. And I think if you look at where we are, this is where a highly reliable organisation is generative. That's how we work. And I think the NHS is probably at the calculative. We have systems in place to manage all hazards. I'm not sure. Reactive. Safety is important. We do a lot every time we have an accident. I think that's where we are. This is where the nuclear industry is and the airline industry is. We've got a long way to go. Last 2 slides. Jeremy Hunt, for you to take home with you. Said on the 9th of March, this is about an NHS that learns from mistakes and not hanging people when things go wrong. This change in culture must extend to trust disciplinary procedures, so NHS improvement will ask for a commitment to openness and learning, so staff can have clear expectations of how they'll be treated if they report clinical errors. I know what happens in some trusts and sometimes in our trust. Next slide. We'll see. Now this is the important one. Airline industry. From 1st of April, he set up the Independent Healthcare Safety Investigation Branch, mirroring the air accident investigation branches that looked at airline industry in a constructive, critical way, in a no-blame investigations that will be open, available to patients. And he's asked the new organisation to consider focusing initially on maternity and neonatal mortality investigation. So that's the new way forward. Investigation, and that started on the 1st of April. Next slide. Okay, so there's my summary. I think human factors are intimately interwoven with how we manage care on labour ward. We need to know about situation awareness, be really aware about level 1, clear leadership, good communication, good followership, and be aware of the negative effects of the environment and stress. But the most important thing, next, is we need time and funding to train in it. It won't just happen. You've heard about the difficulty of doing some simulation training. Next slide. Remember that as the most important slide, and I think if you hit it, the end.